Our first session today will be moderated by Vinyas Harish. He's MD and PhD candidate at the U of T's Faculty of Medicine and Dalalana School of Public Health, and is also SRI Graduate Fellow. So yeah, over to you, Vinyas.
Thanks so much, Asmita. So this morning we have a really interesting session focused on health and well-being with speakers from the Temerity Faculty of Medicine's Department of Laboratory Medicine, Pathobiology, Translational Research Program, as well as U of T's iSchool. So I'll start off by introducing our first set of speakers. Ellis and Radhika will be presenting their scoping review of patient perspectives on AI. So their research team is composed of Master of Health Science students in the Translational Research Program at U of T. Team members include Ellis Gao, Stephanie Jeanneret Manning, Yamna Elsheikh Ahmed, Mona Renejad, Sally Moy, Mirdad Faharani, Radhika Prabhune, Susan Lawrence, Raza Mirza, and Christopher Klinger. The application of AI in healthcare and medicine is a rising topic of research, but there appears to be limited evidence of patient perspectives on the space. Our goal is to identify and understand the adaptation of AI in healthcare by applying a translational and patient-centered lens. So over to you both.
Okay, so I'm just going to share my screen. Yes, so hello everyone. Today we're going to be presenting our scoping review on patient perspectives and the use of artificial intelligence in healthcare. So my name is Radhika Prabhune.
And I'm Ellis Gao.
And we're going to be your presenters today. So we're going to have a brief introduction just of our team. As you heard, this is our lovely team of 8 students and 2 professors from the Translational Research Master's Program of the University of Toronto. Our work began in February of 2021, and both synchronously and asynchronously, the reviews and thematic analyses are being carried out. So without this team, the scoping review could not have been completed with all of the hard work that's been put in right now. So now on to our scoping review and why we chose the topic of patient perspectives on AI in healthcare. So a bit of background on our team. We come from the Translational Research Program, but something that is really untalked about a little bit is what is translational research. So our program focuses on working alongside target communities and influencing stakeholders to meet their needs in a more effective manner. To achieve this, we use the Toronto Translational Framework, or the TTF, that's displayed on the screen right now. This framework dictates that the first stage of a project is discovery, where researchers are to gain more knowledge about their field and the community they're trying to help through literature analysis and through stakeholder partnerships. This is where the perspectives can be attained and analyzed to better understand a problem. So using these perspectives can assist in identifying real-life issues in the initial stages. So this is where our scoping review can truly aid in translational research. So our project studies the growing field of artificial intelligence, a branch of computer science that has been progressively growing in the past decade. Now, this technology uses different algorithms to learn from the input data and provide information and predict based on current and past information, and constantly adjusts based on the new information that it receives. Now, currently, this technology has already been incorporated into healthcare in fields such as cardiology, radiology, and dermatology. And it has been also used for a multitude of different processes. So these could be used from anything from diagnosis in dermatology, screening in cardiology, to even at-home care for geriatric hospitals. Now, based on our background literature on this subject, it has already covered in many, many fields. So one thing missing from this research is actually the what brings us to our research question. So what are the patient perspectives on this type of technology in healthcare? As mentioned before, a crucial step in any project that aims to intervene on a problem requires the patient perspectives to ensure that any interventions created are actually helping those patients rather than just a project that some people have thought is a good idea. So some of our methods for the scoping review. So we followed the Arksy and O'Malley's framework, as well as using Prisma SCR checklists and different databases to import more of our articles. So the Arksy and O'Malley framework allowed us to structure our scoping review process into something from a broad research question that we currently have to comprehensively identifying relevant studies and then going into charting and collating data for final reporting. The Prisma SCR, or preferred reporting items for systematic reviews and meta-analysis for scoping reviews, is essentially a checklist of 20 items for reporting. For this, we ensured we had 2 people on every single article, and if there was any conflict between opinions on whether the article should be included or excluded, we added a 3rd person for that consensus. Now, for our literature review, we essentially used 7 interdisciplinary databases as we listed on the screen. And then we also looked into gray literature to ensure that we were finding information from every corner of the internet, because as we said before, this is a very limited area of research. Now, some of the criteria we had for this scoping review: for inclusion, we made sure that the articles did mention specifically artificial intelligence or machine learning, so that it was sure that the intervention was using AI. We also wanted to make sure that the patient perspective is provided and was an aim for the study that itself. We also wanted to make sure that the intervention was provided in healthcare settings and published between 2015 and 2022. And finally, we wanted to make sure that the article was in English to be accessible by our team, and that we were using an adult population of 18 years or over, but we also did include articles that had adolescents and adults if it spanned over both ranges. Now, for exclusion, we wanted to make sure that we weren't using non-AI technology. So this included virtual reality, Paro, robot assistants, as well as just simple components that were using algorithms and not necessarily specifying that it was machine learning. We also wanted to make sure that non-patient perspectives, if they weren't providing patient perspective specifically, and only providing information from healthcare providers, families, caregivers, and SDMs, those articles were also excluded. Now, we also obviously excluded the non-healthcare settings, and we also wanted to make sure that our research was primary research and not systematic reviews or scoping reviews in the same field. And finally, if the article was not accessible to the team, it was obviously excluded as well. Some of our methods for identifying themes after the articles were fully prepped and the criteria was met, and the stage that we are right now, the articles are going through the systematic analysis stage. For this, we're using Miro boards to essentially divide up the articles between each team member and labeling the themes and the article on a sticky note to be later organized into appropriate thematic categories, which Ellis is going to discuss in the results section. So I'll pass it on to Ellis.
Perfect, thank you. So moving on to results here, I'm going to start with a flow diagram summary of the Prisma framework. So here you can see that a total of 11,584 references were imported based on the search, and of which 16% were duplicates. So this resulted in a little less than 10,000 title abstract screens. So then at this phase, 87% were excluded based on irrelevancy, resulting in about 1,200 full text studies, which were assessed for its eligibility. Now, during full text, around 97% of all studies were excluded, with the top 3 reasons being the wrong outcome or not patient's perspective, the wrong intervention or not AI, and not being primary research. This resulted in a total of 37 studies that were relevant and were extracted. So we can see that based on the extracted studies at this time, the following 4 figures were created. Starting with figure 1, seen on this slide, it demonstrates the diversity of the included studies based on the countries for which the patient population came from or was studied. We can see that studies were conducted in 7 countries. The most frequent of them were Netherlands and the United States. So here we have figure 2, which is a word cloud created from the pooled keywords with larger fonts representing more frequent occurrences of that word. So based on this figure, the top 3 most frequent keywords are patients, AI, and health. So this illustration then shows that we have successfully identified the topic of the study, which is to understand patients' perspective on AI in healthcare. Now for figure 3, this demonstrates the number or the count of publications per year that we took on. We can see that here, the number of relevant publications has been increasing since 2015, with exception of 2021, as the import cutoff was August for our study. This trend could suggest that there has been more applications or potential applications of AI in healthcare since 2015, such that more research is warranted. So then lastly, we have figure 4. This figure visualizes the type of healthcare settings for which the studies was conducted within. Here we can see that AI is or can be employed across various healthcare settings, but there are major or subtle differences across them. So let me give you an example. In radiology, minor diagnosis can be automated through AI. Now in this field, patients usually have a higher acceptance of this AI adoption because there's usually lower risks associated with this change or adaptation. Now, however, in comparison, other disciplines like neurosurgery, where AI employment could lead to like a life or death situation, this may increase experience in the hesitation or opposition of this change. So that's why it's really important to actually see what the patient's opinion for this AI application is. So then this leads me to the discussion and conclusion section. So here at the current stage, we have used 4 groups to classify the identified themes from the extracted articles. These topics are impact of AI use, accessibility and adoption of AI, tangibility of AI implementation, and ethical concerns around AI. Now, within each group are recurring themes identified throughout these extracted papers. And let me give an example for each of the groups. So with the impact of AI use comes with the worry that certain clinician or physician jobs may be replaced by AI. Now, for the accessibility and adoption of AI, things like language and proficiency to the use of technology are also barriers to accessing these tools. For the tangibility of AI implementation, while it may be cost efficient and faster to have automated work and screening in the healthcare system, this may come at a cost of lower quality of care. Lastly, as for ethical concerns, things like data privacy or the transparency of AI employment within certain settings are items of consideration. So now, given this review is still in progress, we expect that the changes and additions to the findings in the results and discussion material presented here today will be different and there will be changes. So now let me move on to the limitations of our study. So like all studies, there are limitations. And for our scoping review, we've identified 3 main ones. So the first of them is in terms of method, the choice of a scoping review leads to limitations. One of which is that this approach often leads to a broader and less defined search for literature within the field. As well, given the qualitative nature of the study, the analysis was based on themes rather than statistics. Now, this method could be viewed by some as being more subjective than potential quantitative studies in this field. Lastly, in terms of interpretation, one limitation is that this study was manually screened. This leads to differences in opinions and interpretations of the extracted content, which could be viewed again as being subjective. So now, in terms of timeline, so at this point of time, our project have been proposed and approved. The parameters to our study to study our objectives have been set. The screening based on these parameters are complete, and the data has been charted through extraction and consensus. We're currently in the process of data synthesis, where we look at or look to dissect the themes and to have a more systematic categorization of these themes and categories or topics that we see. But towards the tail end of this timeline, we look to have consultations from stakeholders. And as the final product forms, we look to have knowledge dissemination through presenting our findings in conferences like this and publishing the final work when we're done. Now, lastly, to end off, it's important to reemphasize the goals of this study. So goal 1 is to identify the gaps and barriers between AI development in healthcare and patients' needs and expectations. Goal 2 is to provide an impetus for future research into the implementation of policy changes for AI use in healthcare. So here are our references and a summary poster for the content that we've presented today. Thank you for listening.
Thanks so much, both of you, for presenting this work on behalf of your colleagues. It's very interesting. So we have a couple minutes to chat about your work. And for those of the audience who are new to systematic and scoping reviews, what's you spoke to the limitation of doing a scoping review, but what's an advantage of a scoping review compared to a narrative review?
So I would say that a scoping review's analysis of the themes rather than, did you say a narrative review?
Mm-hmm.
So I think a scoping review has a little bit more of a little bit more analyses than a narrative review. So it's looking a little bit more broadly into the those themes that I mentioned, as well as doing it a little slightly more objectively, in my opinion, than a narrative review would do. And then as for comparing it to a systematic review, it kind of focuses a little bit more than on fewer articles rather than doing as many articles as a systematic review might, as well as the fact that it can look at the qualitative data and the statistical data if that's provided in the articles as well, rather than primarily looking into statistical information. Sorry, my dog is just on my desk right now, so I'm making sure that he's okay.
And I see, Donald, you have a question. Feel free to come off mute and ask. Otherwise, I can read it out.
Sure. I just actually have two questions. One relates to whether or not you have had the opportunity to look at potential sampling biases in respondents in these studies. In other words, typically people who are engaged in this kind of activity tend to be white middle class or upper middle class participants. And do you have a sense of the diversity of input that way? And the other quick question was just with that table you had on the themes, the color gradient, was that just pretty, or did it actually represent greater representation of this theme as you went down that list?
So I don't know if Alice, you want to take that one?
Yeah, for sure. I can take both of those. So I'll answer the latter one first. The gradient is just simply for visual appeal. It doesn't have a meaning to it. As for the first question, so we did, as we were charting the data, we charted all of the age range as well as the patient demographics. And based on what we've charted, we do see a variety and diversity in the patient population that's been included in our studies.
Great, thank you.
And I have one last question before we hand off. You spoke about stakeholder consultation, and that's something that's not very commonly done with scoping reviews, but is really exciting that you're going to attempt to take this, what you find back to the people who are impacted most by it. So can you speak to a little bit how you plan on doing that and what that might look like?
So I can take that. So right now, as we're still in the extraction phase, as well as the thematic analysis, we haven't fully discussed how we'll be doing that. But in previous projects, the way that this has been done is through contacting experts, essentially going through a lot of networking processes to meet new people, as well as kind of a snowball effect of kind of meeting some people and then having them introduce us to new people and then using them as stakeholders as we go on. And that can give us a little bit more of a diverse opinion set as we discuss the scoping review with other people.
Wonderful, really exciting. We look forward to seeing your work continue to evolve over time. So we'll transition now into our next session, and the presenter for this session is Camila Ibrahim, a Master's of Information candidate at the University of Toronto, focusing on human-centered data science. She recently graduated as class valedictorian from the University of Waterloo, majoring in economics and econometrics, Ibrahim has worked with the UNHCR, Global Affairs Canada, and the UN Economic and Social Commission for Asia and the Pacific. She's passionate about using data science and statistical methods to create explainable and transparent technical solutions. Ibrahim is currently a graduate fellow at the University of Toronto Centre for Ethics, focusing on the ethics of AI, and a research intern at the Brookfield Institute for Innovation and Entrepreneurship. So welcome, and feel free to get started.
Hi, thank you so much for having me. I just want to make sure that my slides are visible.
Yep, we can see them.
Perfect. So thank you so much for the intro. My name is Camilla. I'm very excited to be here today. Part of this research has been funded by the University of Toronto and also by University College of London. So I just wanted to start off by saying big thank you to them as well. And I'm really grateful to be part of this project and to have the chance to share it with you all today. So I began to be interested in urban technologies and kind of how we can make them better when I started my work at the University of Toronto Faculty of Information in a course called Data in the City. So basically what we were looking at was how data is used in urban centers and the ways that people's experiences with public institutions like the police or the social services really differ depending on their race and on their income. So what my work did is then apply this to the current moment that we're living in, which is obviously the COVID-19 pandemic, when this work was being done. And it's in particular because of the way that these two factors impact your live experience. So the way that your race and your income level really impact your live experience. Some people in Toronto will go their whole entire lives without ever interacting much with, for example, the punitive system or with the police in particular. And some people interact with the police every single day. So the very real experiences that we have change the trust that people have in different public institutions. And it turns out that trust, as I'm sure we're going to hear from other speakers today as well, is hugely, hugely important in getting people to buy into and adopt new technologies. So we often design technologies by thinking of trust as a uniform construct and thinking about society's trust in technology as a kind of singular narrative, which isn't it at all, right? So there really is a dynamic that I was trying to understand with my research as it relates to lower income racialized Torontonians and their interaction with policing and government and surveillance, and then also how does that extend to contact tracing apps? So the way that contact tracing apps work is that they collect Bluetooth data from users and then trace back the people an infected person has come into contact with. So as an example, if I had come into contact with somebody with COVID, I would get a notification on my phone only if I've decided to have the contact tracing app as part of my daily smartphone, that kind of thing. We know that contact tracing technologies are hugely impactful and really do help to stop and curb a pandemic when they're used correctly. So a case study that was particularly good at this was Taiwan. So they had almost no lockdowns at the beginning of the pandemic. They had almost no community spread. And the credit that public health workers really gave was to good contact tracing apps. So as the slide says, in order to be effective, a contact tracing app needs to be adopted by roughly 60% of the population. That's just in order for it to be somewhat effective. Canada's contact tracing app had an adoption, particularly in Toronto, had an adoption of 12%. So obviously that wasn't enough to have the impact that we wanted. And so what I started to look at was, well, why was our adoption so low? This research comes from primary studies that included Canadian participants, but also included participants from countries similar to Canada, also with low adoption rates. And so the question was really about the questions that participants had, or the reasons that they were reluctant, was really around understanding how data will be anonymized. Will the data be shared with law enforcement? Will the data be sold for commercial use after the pandemic is over? These were not questions that the public had answers to and had access to. It wasn't part of informational campaigns. It wasn't part of the push to get people into contact tracing. So really what we learned through understanding people's reluctance was that user privacy and data concerns was the main problem, but a general lack of trust in institutions, especially as it pertains to racialized and lower income Torontonians, was also a main factor in the maladoption of contact tracing. So as I mentioned earlier, we know that trust is not a uniform construct. And so in developing technologies, trust should not be treated as though it is a uniform construct. Technologists know from researching other technologies like facial recognition, as an example, that your personal experience or the experience of the people around you in your communities, in your local religious institutions, the people that you go to school with, really dictate your perception and how likely it is that you are or aren't going to trust in a public institution. In Canada, we know, and also in the United States, we know that this is especially true for Black communities who are more likely to have been the targets of police brutality and have been disproportionately harmed by technologically enabled infrastructures. So thinking of things like predictive policing or facial recognition technology. That is also true in the Canadian context. One of the interesting things with this research was the first summer of the pandemic also coincided with a massive movement of Black Lives Matter, where facial recognition and predictive policing was used at scale on protesters. And so you kind of had this dual push, like, we're going to use your face to kind of incriminate you when you're protesting, but we also want you to voluntarily adopt this technology that we're telling you is tracing. So it was a very interesting dichotomy of how those two rhetorics were being pushed at the same time. In Canada in particular, another community of note is Muslim communities who have been disproportionately held the targets of police surveillance and have been over-criminalized through surveillance. So that was another community that we were able to see with low adoption rates. So what does this mean for technologists? My context is usually working in human-computer interaction or working with other researchers who think about how we design technologies. And how we design technologies is very important to the way that people trust and the way that we impact health, right? So we also know in terms of contact tracing that the communities who were least able to be protected by measures like working from home were also the most to gain from contact tracing apps. So we kind of had the most at-risk communities being low income, being more likely to be able to have to go into work. These were the communities that had the most to gain from contact tracing because it was an added layer of protection from the coronavirus. However, they were the ones who were least likely to trust in these institutions and had most been impacted by privacy breaches in the past. These were also communities in Toronto, especially, that were the most over-policed. So if, for example, data collected for public health is combined with other demographic and socioeconomic data, there is a large and significant chance that it will be used to create behavioral profiles in a population, which is then assessed for their potential to engage in other risky behaviors. So we really have to protect against these things and make it clear from the onset that we are designing technology with good data practices, with good privacy policies from the outset, so that we don't have a crisis of trust and we don't have public adoption rates that were so low as the ones that we saw. And I would also suggest that there is enough precedent for these practices, for community engagement and for large informational campaigns to suggest that such an occurrence, especially as it relates to privacy, is possible. We really want to kind of make the point that if you design a technology that is not considerate of the social and political nuances and the very real and very present stratifications in a society, then we are not designing a technology that is going to be effective. Furthermore, if we avoid the risk of surveillance by over-policing in a way that it is not initially meant to do, as I said, we were really causing a crisis of legitimacy for public institutions. So the way that I kind of want to model this is with two users. So if we have user X, who is a Canadian citizen and works from home, and user Y, who is an undocumented person who works in a factory and therefore cannot work from home and lives in precarious housing, we can kind of understand that one user here is going to be more likely to adopt that technology versus the other one. But we can see that user Y would have much more to gain as they can't work from home and as the contact tracing would have been an added layer of protection for them. So in terms of best practices for designing for trust, we know that we're operating in very neoliberal contexts where adoption is voluntary, and therefore there are different models that can still be effective. So one of the models that we looked into from other countries who were similar to the Canadian context was third-party governance. So really having the government hand off the data to a third party, and the government ownership, if at all, comes with strict protections that are very clearly communicated to the user base. That would make it more likely to have folks who would want to engage with this technology. And the government-owned model also follows the European model, which owns and collects the data, but has very strict laws, something that we haven't yet seen in the Canadian context. And some general principles that can be applied to all sorts of technology, but especially with respect to personal data and especially with respect to health data, there's a couple principles. So the first one is transparency. So being very transparent about the data pipeline, about what information is being collected, how it's being transferred, who owns it. All of those things need to be clearly communicated, which is their second principle, in a way that the average person who's not a technologist, who doesn't have a master's degree in data science, can understand. We're designing technology for the most part for the public, and so the information that we're communicating must be for the general public to understand. So clear communication here is really important as well. Another principle that is really important is single-use data. So one of the ways to avoid the risk of surveillance and therefore over-policing and over-incarceration is that data should be used in the way that it was initially meant to be. So if, for example, I collect location data for contact tracing, it should then only be used for contact tracing. We have seen that data is often amalgamated in public institutions. This happens more so in the States than it does in Canada, but that said, there aren't currently enough privacy restrictions to enforce a single-use data policy, which causes a real crisis of legitimacy for public institutions. And what we've learned over the pandemic is that if people just broadly don't trust your systems enough to opt into the right parts of it, then it's not going to be adopted well. And it's not necessarily on the user, it's more of a systemic flaw. If the risk of surveillance is so great that protecting your health or your community's health isn't worth it to you, then we really need to recalibrate the way that we communicate data constructs. And single-use data usage is one of the ways that we can do that, because we're making it clear and we're embedding those data and those privacy rights in the design of the technology in the first place. The last principle is just to understand the limits and to participatory design. So participatory design, for those of us who are not familiar, is the idea that we include communities who are going to be affected by the technology's use in the design of that technology. So as an example, in a contact tracing app, we would enlist the communities who we were most at fear that they wouldn't adopt it in the design. So what would make you adopt it? What would relieve some of your reluctance and your reservations? One of the things that HCI researchers in particular over the past couple of years have made really clear is that while participatory design is critical, it also has its limits. So we don't want to overburden communities, especially, for example, who are going through a pandemic and have other problems that they're facilitating, without understanding what those limitations are and what the research burden in a community might be. So that's really important to us as researchers as well. So I'll just leave you with one of my favorite quotes, which says, "The inattention to the specificities of local politics and the power relations among the multiple stakeholders involved in a development project often contributes to the increased marginalization of oppressed groups while further entrenching existing power structures." So we really want to understand how what we do at the local level exists and entrenches power structures societally, and how we can begin to design technologies at the civic, at the urban, at the local level that will then work to help health concerns, help surveillance concerns, and really provide a healthier city through the mindful and responsible design of technology. Thank you so much for having me. I will now welcome questions.
Thanks so much, Camilla. That was a really fascinating talk. So to kick us off, you spent most of the talk talking about your findings, which were really interesting. Could you speak to a little bit about your methods and how you actually derived all these findings?
Yeah, absolutely. So we tapped into existing research for this project. We looked at the way that, so we really drove home what has been successful and what can we apply to the Canadian context. So looking at things like Taiwan, we also looked at the Bahrain case study where they also employed contact tracing. It's a little bit different when you have less stratifications within a city. So here we have very clear stratifications based on race lines or income lines. And so it's a little bit less of a one-to-one. So in combination with the successful case studies, we then looked at research and user data to see, okay, where was it being adopted in Toronto? And if certain neighborhoods have really adopted contact tracing and certain ones haven't, what insights does that lead us to? I think a future extension of a health study could be going on the ground and doing a lot of survey data. For this project, we were a little reluctant to do that just because I mentioned the burden of surveys, especially in the midst of a pandemic. But I think that there are responsible ways to do that. And I really hope that a future iteration of this project looks like that as well.
For sure. You also spoke to third-party governance. In your research, did you come across any examples of jurisdictions that were actually able to do it?
Yeah, so actually the European model, which worked relatively well, I don't think that the European model had as much funding for contact tracing, so it was ultimately scrapped, but that was their model. And that is their model for a lot of kind of data privacy concerns that collect personal data or collect data at the personal level, is that even if the government technically owns that data, it's kind of handed off to a third-party trust. Which is something that could work very well, I think, in Canada, and especially as it relates to health data, because then the government, there's very strict limitations on what can be done with that. So although the government technically owns it, they're not able to use it without the explicit consent of the user and without the governance of that third party.
Gotcha. And the last question that, Donald actually has a question, so please
go right ahead. I can go after you.
No, please go for it.
I was just going to pick up on your principle around single use of the data.
Mm-hmm.
That is a very conventional privacy construct in a spectrum that goes all the way through to open access and open use and being non-specific. Certainly in the public health context, there are tensions in terms of the ability to make multiple uses of this information for understanding epidemiologic trends, being able to make some policy decisions beyond simply has this person been in touch with or been close to an individual who could potentially infect them. And in fact, that may have been part of the problem of adoption in this
Mm-hmm.
area. The early on message that this is not good, that government might get their hands on this. So do you want to comment to that at all about the whether we should be at that polar extreme or there are steps in between, like limited uses that are directly related to COVID-19 management, or limited public health uses, or limited health uses, or limited research uses, all that kind of thing, and how we can manage that these days, especially in light of this conference talking about AI. All sorts of people who are interested in data science would love to get their hands on this and do analyses of it. But we're saying right off the bat, no, can only be used for contact identification.
Yeah, absolutely. And I think you hit it right on the head, right? There's a whole spectrum of the way that we use data. So all the way from single use to open access. I think what's important to keep in mind as a designer of a technology that is being deployed for at-risk people is that there are always trade-offs. So in a single-use context, you have the ability to really drive home, like, this data is only going to be used for this. As you increase those uses, you have trade-offs. So contact tracing, especially in, like, rewinding back to 2020, was a very interesting time because we had to really deploy that technology quickly in order for it to be used, right? So now that we're kind of 2 years out, I think we can make better use of, like, the lessons learned and really think through what those trade-offs are. Personally, I think that when trust is such a huge issue in terms of contact tracing, it would be better to have less, data scientists use that data down the road, maybe fewer studies that come out after, but have a higher adoption in the moment. And what some folks who were kind of also researching in this space were advocating for was a 2-week expiration of the data, because we know that the incubation period for contact tracing or for COVID or whatever is like whatever was like 21 days. So after that 21 days, we don't need to hold that data anymore, it disappears. And the idea was that we need to get up to that 60% adoption rate in order for this technology to be effective at all. And so having a single-use policy is one of the ways to really drive that. But again, like there are of course trade-offs. I think single use can be mitigated if you have a really clear communication strategy at the government level. And really it's just about taking those principles, understanding them, and then seeing at which level we want to use each of them. And hopefully that we hit a sweet spot where we're able to leverage all of them in some way.
Thank you.
Great, thanks so much, Camilla. We'll now transition to our next speaker, who actually works with you, Camilla. So I'll introduce Erina. Erina is a Master of Information candidate at U of T. Her research is within the interdisciplinary area of human-centered data science. She combines the social sciences with statistics and computational technologies to study how computing can be used for social change in the public sector, particularly in the field of child welfare. Prior to joining U of T, she received a BA in economics from the University of Chicago in 2014 and worked in finance as well as education. So over to you, Erina.
Hi, thank you so much for the introduction. Camilla and I will be presenting today on our talk, and I think Camilla will be sharing her screen. So,
yeah, perfect.
Okay, so our talk today will be about building algorithms that work for everyone, natural language processing tools for bias reduction in child welfare systems. My name is Erina. I'm a Master of Information student at the Faculty of Information, and I'll be an incoming PhD student at the same faculty in this fall.
Yes. I'm not going to introduce myself because you just heard from me, but we also just wanted to thank our supervisor, Dr. Shayan Guha, for his support, and Devansh Saxena for working with us and for helping to inform our research. So today's agenda for our presentation, we just want to walk you through our background, provide a brief history of child welfare service algorithms. We're also going to walk through the most common algorithms, so CANS and 7EI, and then again, going into design guidelines, our NLP solution that we've developed for this model, and then explain a little bit about future work, and then of course host a Q&A.
So before we go into our research in detail, given that the subject of child welfare algorithms affects vulnerable populations in the US and worldwide, we believe it is important we start this talk by acknowledging our backgrounds and our relationship with child welfare. By acknowledging our positionality in this research space, we recognize our backgrounds can inform and influence how we perceive, understand, and present our research findings. So I myself am Asian. I've lived in the Midwest in the US for an extended period of time.
I am Tanzanian Canadian. I have lived in Toronto almost my whole life. And Erina and I have not been investigated by a child welfare agency or have been adopted or gone through the foster care system.
Okay, so to begin, we want to provide a brief background into decision-making algorithms used in the public sector to sort of situate our research. In the context of the US, where we conduct our research, the use of algorithms is not new and has arguably been implemented since World War II, starting with the collection of data on citizens using statistical analyses for policymaking, service delivery, population management, and so on. What is notable, however, is their pervasiveness, scalability, and personalization these days. They're entrenched in power distributive powers of the state and can influence decisions on a large scale and can target individuals or population groups now. These algorithms are currently used in the criminal justice system to assess recidivism risk, in healthcare to decide who gets what kind of services, education to measure teacher effectiveness, as well as in child welfare, where we will be focusing our research.
So why and how are our algorithms used in child welfare? So there are numerous reasons for their adoption. The child welfare sector faces limited funding, overworked staff, and as a result, high staff turnover. There is also a lot, and I would argue a disproportionate level of media scrutiny related to child welfare tragedies or the traumatic and unwarranted separation between families. So in light of these factors, there have been a demand for objective decision-making. Currently, the algorithms are built using administrative quantitative data and are used to assess the risk of maltreatment, the level of need, and placement stability. They're also extensively criticized for omitting outlier cases when building the algorithms, targeting the poor or racialized groups, and focusing on the deficit, increasing a sense of mistrust towards the child welfare system and their algorithms by families and social workers. So the main idea here is that algorithms should be used to augment decision-making processes and not supplant them. So we mentioned trust, and we really think that having algorithms be used as an assistive measure and not a definitive measure will help to increase trust in the system itself. Algorithm decision-making should support human discretionary work, but it shouldn't totally replace it. So decision-making algorithms that are solely quantitative, using only data and are then used in child welfare services can produce biased outcomes with respect to racialized or low-income families, especially in a high stake context like child welfare services, where children's health and well-being is at risk. The need for caseworkers to not rely solely on algorithms is so important, and we hope to demonstrate how a reliance on algorithms that are solely data-driven really removes context and hinders the reunification process disproportionately to the detriment of racialized and low-income children, thus further entrenching the lack of trust that we've already seen within these communities. We also know that there's a clear misalignment with policy goals of reunifying families regardless of race or income. These are also the decision to therefore keep children from their families, and therefore the reduction of bias should be a key consideration for both technologists and policymakers. And as alluded to earlier, these are very context-rich environments. So given the history of social services and child welfare services in North America, we really need to advocate for and develop context-rich algorithms that need really has become apparent to the both of us through this research. And so the central question for our research and for our talk is, how can we build an algorithm for child welfare services that works for everyone?
So we want to briefly explain why algorithms came to be used in Wisconsin, where we focus our research. So all the states in the US have different laws and policies surrounding child welfare. In Wisconsin, in particular, if we go back a few decades, in 1993, the ACLU brought forward a lawsuit to the state of Wisconsin for failing to provide adequate child welfare services. A settlement was reached, and the state was mandated to comply with 13 requirements to improve the sector. And the state was able to make good on the majority of the requirements. Placement stability was the anomaly and was an area the state still needed to work on until recently. Research shows that the best thing for a child is to have placement stability. What we don't want is for a child to be moving through homes or centers in the child welfare system for years. Placement stability here is a technical term used to refer to the likelihood that a permanency plan will remain effective and in the best interest of the child. To alleviate this burden, the state implemented algorithms at several stages of child welfare cases to assess a child's risk of maltreatment and their level of need. To aid in the process, the state decided to implement algorithms at various points of the child welfare process, which we will explain going forward.
So within our work, we're building on Devansh Saxena's research that conducted an extensive ethnography at the same agency that we partnered with, conducting interviews with caseworkers and observing caseworker meetings to understand their daily practices and their perceptions towards decision-making algorithms used in child welfare services. So there are many different algorithms that go into child welfare services, but the main two that we want to focus are CANS and 7EI. We really would just want to highlight how the two algorithms optimize for different factors, and as you'll come to see, which ones lead to better outcomes generally. So in a nutshell, how these algorithms work, we're hoping to provide an overview for context, but if additional detail is requested, we're happy to take questions in the Q&A period. So overall, CANS, which is what you see on the screen, is mandated by the state, but in general, it lacks context. So it's conducted every 6 months, and the caseworker will interview the foster parents and ask them about any changes in the child's behavior, risks, needs, and that information is then fed into the CANS algorithm that produces recommendations. So that includes recommendations on the level of foster care, so where the child should be, the compensation recommended for the foster parents. And the level of foster care is often ignored in subsequent assessments because you generally, as a caseworker, don't want to disrupt the placement unless things get worse, like notably worse. And based on mental health needs, the foster parent compensation is recalculated. So based on mental health needs, it recommends services such as individual therapy and determines the level of foster care. The higher the needs of the child, the higher the compensation offered to the foster parent. In practice, this can cause problems because CANS paints an isolated view of the child without understanding the traumatic triggers in their ecosystem of care. And because higher mental health needs equates to higher compensations within this model, CANS lowers the compensation to foster parents who work hard to help a child cope with trauma. Because of this, oftentimes we see that caseworkers adjust the CANS input details so foster parents can still get a higher rate or retain the same rate that they had been getting prior. And this inputted data is then used to build on and drive the CANS algorithm. So the incentive model for the parent therefore changes when the CANS algorithm is used, and it thus contradicts the theory-driven practices that we know to be true in child welfare services. So just going to read a quote from a child welfare supervisor, which says, "It is the complete opposite of what we want it to do. Foster parents help minimize the behaviors and offer support so that kids can develop good coping skills. They help address the mental health needs and help kids stabilize by taking them to therapy and all their activities. But then they're punished because the kids' needs go down and so does their rate. Their rate referring to the compensation that foster parents are offered. And this is pretty indicative of what caseworkers feel across the board. Essentially, that CANS lacks context and focuses on current behavior, but not trauma or triggers, and isn't holistic and contextual in that way."
So in contrast to CANS, we have 7EI. 7EI is a locally developed algorithm which centers in trauma-informed care. It is not legally mandated and implemented and developed by the Child Welfare Agency where we conducted our investigation. Caseworkers note that 7EI is useful because it allows room for discussion and provides a comprehensive view of the child and their ecosystem. So the algorithm is designed to be used in a team setting so that the expertise from the entire team can be leveraged and decisions are made through consensus decisions. What happens is the team discusses and scores the child's and the caregiver's wellness on 7 domains as depicted in the figure here, and they collectively think through solutions. So it's based on trauma-informed care, which has also been proven to improve child outcomes such as placement stability and permanence. 7EI assessments are individually focused. However, unlike CANS, the results are trauma-focused and also guide family interventions, highlighting the areas of child's functioning upon which the caregivers and professionals should focus their attention. So 7EI is also usually the first step in a series of decision-making in child welfare cases. So it's a prescriptive tool that assesses a situation using a prescribed framework. So here's a quote from Devansh's paper on caseworker perceptions around 7EI. "We have tried the cookie cutter approach in the past, assigning everyone to parenting classes, therapy, and other support services. It failed and it is horrible to do to a family. So with 7EI, we focus on addressing core issues, whether it's the parent's self-esteem, their own abandonment issues, or child's emotional regulation that will help this family." Clearly, the addition of context works well in 7EI, but it's not enough, which brings us to our next section.
So what we've really learned by looking at these two algorithms in comparison to one another and seeing how they impact child care and an assessment of other algorithms used in child welfare is that there are design guidelines that are suggested based on an audit of these, and other algorithms are as follows. So back to our initial question, how do we build better algorithms? Our method was to use topic modeling, and Irina will expand on this, but I just wanted to give a brief intro to what topic modeling is. To give a brief overview for those who are not familiar with it is a group of statistical methods used to infer latent topics that occur in a collection of documents, relying on word distribution in each document. So it is a natural language processing technique that is not supervised. It really helps us to go through years of case notes very quickly, and works on determining what are those key topics that we need to be mindful of, and then allowing us to have a distribution of them over the text documents.
Okay, so back to our initial question, how do we build better algorithms? So we think that the secret ingredient here lies in text data, collecting case notes, collected case notes from caseworkers. So in our research, we adapted the approach taken by Antoniak et al.'s paper, Narrative Paths and Negotiations of Power in Birth Stories, published in CSCW 2019. By applying topic modeling on child welfare case notes. So we first pre-process, clean the data for analysis, removing punctuation, anonymizing any identifying information, and so on. And then we apply topic modeling using Mallett's implementation of LDA, which takes a bags of words approach to determine topics in our case notes. So it doesn't really care about the word order. We analyze the topic model solution, applying a quantitative and qualitative approach to our analyses. So manually assigning labels to our topic model solution and member checking our interpretations with workers at the agency to validate our labels and to get some feedback. We also looked at how topics change over time for the different families at the agency.
So from topic modeling, we were looking for words or the themes that are most likely to occur. There is a lot of math that goes behind this, which I won't go into today, but in general, we're using natural language processing to search for patterns in the text data. And for the sake of time, we won't go through all of them today, but our topic model solution showed that there were about 17 topics in the case notes that highlight the invisible labor conducted by caseworkers. So just note that the topics lower down on the list mean that such topics appear less frequently. So for example, topic 1 focuses on conflicts during visitations, which caseworkers help resolve and manage conflicts using different soft skills and social worker training within the parties. Topic 3 addresses the medical aspect, and topic 12 covers court proceedings, so the legal aspect. And topic 14 also shows an important finding, which indicates that this topic appears, what's interesting here is that this topic is 14th out of the 17 topics. So that indicates that it appears less prominently than the other ones in the case notes, and that caseworker assessment scores play a vital role in algorithms such as CANS, but the low importance of that topic shows us that it's kind of on the periphery tasks of the caseworkers.
So in addition to looking at the topics that emerged from our topic model solution, we also looked at how topics changed over time. So we grouped our families into 3 groups based on their number of interactions with the family, and found that these 3 different groups had low, medium, high needs, differing needs. So caseworkers were working with families that were not a monolith, but actually very different families with very different needs. And there were different topic popularity changes over time for each of these 3 groups. So one of the topics that you see here on the very right of the screen is coordinating virtual interactions. This was a topic that emerged from our 17 topic model solution in light of COVID, where a lot of interactions or visits, court sessions happened online. And what we noticed most particularly interesting was for group 3, the purple line that you see on the top, is that this topic was really prominent for group 3, the high needs families, and less for group 1 and group 2. And this made a lot of sense because group 3 family, any important critical meetings took place virtually, but anything that was deemed less important was postponed or delayed because of COVID. And just going on to the next slide. So our study revealed interesting insights. Case notes revealed the wide breadth of work done by caseworkers, which were not necessarily obvious in job descriptions or at the 2-year ethnography conducted by DeVonch at the same agency. We also found families in child welfare are not uniform, and caseworkers provide different services based on their different needs. So all in all, our research showed child welfare cases are very complex, and current algorithms can't account for the nuanced caseworker activities and family needs. And this ultimately brings us back to the question, what kind of algorithms or technological tools do we need in child welfare, and how can we introduce such tools that engender trust among stakeholders?
So to summarize, we know that topic modeling is a powerful tool to discover the themes in caseworker narratives. The text has really helped us to reveal the invisible work practices and constraints faced by caseworkers. Text is a viable resource to build more trustworthy tools in child welfare. And Arena will discuss future work.
Yeah, so our research showed case notes can reveal rich contextual information on child welfare cases that we really need in child welfare algorithms or tools that are used in child welfare at the moment. So our next step will be needing to compare specifically how quantitative administrative data that's used to build current algorithms compares with textual information from case notes, and how we can incorporate the two or either one of them in child welfare cases.
We know that there are still a lot of legal and policy frameworks that are needed, but we hope that the future of child welfare looks like technologists and policymakers working together towards a future that has more trust in the system. Thank you so much for having us, and we will now welcome questions.
So unfortunately, we'll have to jump to our next session for time, but we'll have time afterwards to discuss further. So next, I'd like to welcome up sai-amrit and Kimberly to present their work on interinstitutional communication in diabetes care. So sai-amrit is passionate about patient-centered care, which is why he hopes to pursue a career in family medicine. Currently, he is pursuing his Master's of Science in Translational Research at the University of Toronto. Within this degree program, he's become increasingly interested in investigating the current state of health data exchange, as he believes improving this may yield better patient care. He currently works in Dr. Rulan Parekh's lab at the Hospital for Sick Children, where he assists in pediatric nephrology and organ transplantation studies. And prior to his graduate studies, he completed an honors Bachelor of Science in Biological Sciences. We also have Kimberly Krasta presenting today. Having been a patient for much of her childhood, Kimberly recognizes how critical it is for healthcare providers to combine the science with the human touch. She believes an effective healthcare system supports the person holistically and encourages active participation. In following her passions, she is a grad student at the University of Toronto, completing her Master of Science degree in Translational Research. Prior to this, she graduated with an honors Bachelor of Life Sci co-op, double minoring in chemical biology and psychology at Mac. Ultimately, she hopes to be an emergency physician. So Sai and Kimberly, on to you.
Thank you. So hello, everyone. Thank you for having us today. Today, Kim and I will be discussing the influence of interinstitutional communication on healthcare delivery and its impact on patient quality of care, as well as trust in the healthcare system. And so this is based on a recent study that was completed by my team and I. So as you can see on the screen, here's our itinerary for the duration of our presentation. We will introduce you to our team and give you a brief overview of the program that we're a part of, which is the Translational Research Program. Then we'll dive right into our study and the next steps of our research. So our research team can be seen on the screen. It consists of Mohammed, Kim, Ellis, who presented earlier, Jessica, Siobhan, and myself. We are all finishing up our first of 2 years in the Master of Health Science in Translational Research Program, which is within the Department of Lab Medicine and Pathobiology, and ultimately within the Faculty of Medicine. So before we enter the world of interinstitutional communication, which is quite a mouthful, let us first delve into what translational research really is, which is essentially the crux of our program, as this is crucial to understanding the entirety of our project. So as Radhika and Alice previously mentioned, the Translational Research Program, or translational research, is geared toward taking research, untapped resources or interventions, pharmaceuticals, medical devices, and technology, and applying it to gaps in healthcare with the goal of making a positive impact on the lives of patients. This involves working through the Toronto Translational Framework, which can be seen on the screen, where we identify patient-centered needs, verify these needs through critical analysis, prototype our interventions, and test it to ensure that we are truly addressing a tangible need. So as graduate students, the following environmental scan was the deliverable for our student-led work and research module, AKA our SWARM course. So now let's dive straight into our project. As COVID has taught us, smooth communication between the multitude of specialists working together is paramount when their information will have impactful consequences. From observations and firsthand accounts, especially for those with complex conditions, we notice fragmented communication between healthcare providers. So with the goal of improving the quality of care for patients with complex conditions who would typically need multiple specialists who practice out of different institutions, we identified the foundational need that our project would be centered on, which is the need to improve care coordination for patients who receive care from multiple health institutions. Through our investigation, we realized that patient care is interinstitutionally fragmented, and it was due to technological gaps and barriers in health data exchange. So how do we get to the specific point of barrier identification? Let us take you through the process. So we conducted a 14-week investigation to identify the barriers to complete care coordination and efficient communication. So in the first week, we defined our scope and research question. In week 2, we identified which stakeholders we would want to speak with. Between weeks 3 and 10, we spoke with these stakeholders for our environmental scan. From the 5th to 10th week, we compiled all of our information from these stakeholders. Between weeks 9 and 10, we identified common or overarching themes. And finally, during weeks 12 to 14, we created a communication paradigm. So let's further investigate each step. Recognizing that care coordination and communication is an extremely broad problem space, we knew that we had to narrow our scope while getting some of the answers that we were seeking. We conducted an environmental scan of the state of communication and care coordination within the type 1 diabetes mellitus space. So why choose type 1 diabetes mellitus? We decided to perform this environmental scan within the specific domain because type 1 diabetes mellitus is a complex diagnosis with many associated comorbidities. Thus, patients diagnosed with this often have to visit their family physician as well as various specialists who practice from different institutions. We felt that narrowing our scope specific to this problem space would enhance our understanding of fundamental issues within the exchange of patient health information. So let's delve into type 1 diabetes mellitus just to provide a fundamental understanding of the diagnosis. So type 1 diabetes is a lifelong chronic condition that is caused by a deficiency in insulin production. The onset typically occurs during childhood. Without insulin signaling, glucose cannot enter the cells and sugar builds up in the blood. To lead healthy lives, people with type 1 diabetes mellitus rely on insulin treatment. Type 1 diabetes management is self-directed. So people with this condition use continuous glucose monitors or glucose meters to monitor and check their blood sugar regularly. And they keep track of their nutritional intake and physical activity since these factors have a direct impact on blood sugar levels. Lastly, insulin must be administered regularly, especially around meal times, to allow the body to utilize sugar for energy and to keep blood sugar levels in a normal range.
So we decided the best way to convey the interworking of T1DM patient care would be to personify a patient with type 1 diabetes so that you can understand the struggles they're exposed to. So meet Ryan. As you can see, he is an interesting guy with many hobbies and interests. He lives in Toronto, loves music, computers, definitely cats, and is an avid Maple Leafs fan. You wouldn't know that he lives with type 1 diabetes from an outside glance. Every day he puts in a lot of effort to keep himself healthy. Unfortunately, kidney damage is a common complication of diabetes, and his doctor suspects that his kidneys may be affected. Likewise, these past few months have been quite tough for Ryan. With the ongoing pandemic, Ryan has been isolated from his support system for quite some time. Work-related stress and living with a chronic condition in isolation have taken a bit of a toll on his mental health, and he is now considering reaching out for some professional help. So we identified our three main stakeholders that would be involved in Ryan's care: an endocrinologist who would meet with the patient every 4 months and will be responsible for managing their diabetes by monitoring blood sugar trends, recommending insulin adjustments, and monitoring for diabetes complications. The family doctor is another healthcare provider he will be seeing regularly for checkups regarding his overall health and well-being. His family doctor has known him for a few years now, and they have a good, trusting relationship. As with most patients with T1DM, Ryan also sees an endocrinology nurse regularly. The nurse plays a very important role in helping Ryan live with diabetes. She helps design a daily insulin administration plan, and she teaches him how to use new gadgets such as the continuous glucose monitors and insulin pumps. She's generally available to correspond over email or even meet over for an appointment as needed. So to understand what a typical appointment would be like for a patient with type 1 diabetes, we reached out to relevant stakeholders in our school and social network. So the size of our group meant that we had colleagues in various different fields. For endocrinologists, we had a conversation with them about what their job entails and what a 4-month checkup would look like. We learned that before the regular appointment, the patient always completes blood work and urinalysis that the patient and the physician then go over together so the physician has a better understanding of what the last 4 months have looked like for the patient. This also helps the endocrinologist pick up on any diabetes-related abnormalities. Should there be any abnormality, for example, proteins in the urine, like in Ryan's case, the patient will be referred to see a specialist to determine if there is any kidney damage. So note, it is not uncommon for a specialist to practice out of a location different than the endocrinologist or the referring physician. At the end of each endocrinology visit, a post-consult report is generated and will be sent to the family doctor via fax. Although the post-consult report contained details of the appointment and the possibility of diabetes-related complications, some PCRs do not give explicit recommendations on how the family doctor should support the patient, leaving the family doctor a bit confused about next steps. So when the patient, Ryan, meets the specialist, in this case the nephrologist, they decide on investigative steps and next steps. Like the endocrinologist, a post-consult report is generated. However, in this case, it gets sent to the referral doctor, so the endocrinologist. So unless the family doctor's information was passed along with the endocrinologist due to the time of referral, the specialist would not have those contact details, thus leaving the family doctor out of the loop. So when Ryan was speaking to his family doctor, we know that the family doctor is mainly responsible for maintaining his overall health and well-being. So during a regular appointment with the patient or Ryan, they discuss his endocrinology visit and any other concerns, and in Ryan's case, struggling with his mental health. While the family doctor received a post-consult report from the endocrinologist, they did not know of the nephrology visit and what it entailed, since they didn't receive the PCR. Now, unfortunately, the family doctor would rely on the patient or Ryan to convey all the details of the appointment. Having to recall all the clinical aspects of the conversation is a heavy burden on the patient, and definitely details get lost in translation. This leaves the patient confused and not knowing what the next steps are. So if most of the appointment is spent catching up the family doctor, then what time would they have to discuss other non-diabetes related issues? Additionally, the doctor chooses to refer the patient to see the specialist. The fax is a typical method, which is highly prone to malfunction or breakdown. The patient is left in the middle without proper information about their care and what would the next steps be to address all your concerns. So it is obvious to see that communication practices between Ryan's doctors are not ideal. The communication system causes problems both for Ryan and his doctors. For example, the endocrinologist would have no way of knowing whether the family doctor received the post-consult report. They would also not know whether the family doctor has understood and implemented the recommendations. On the other hand, the family doctor would be uncertain about the tasks that they should take on. The delegation of responsibilities was not made explicit in the post-consult report. So as we compiled all this information that we gathered from the different conversations that we've had with our colleagues about their experiences of interprofessional communication and care coordination for their patients that have complex conditions, we started to notice three overarching themes. First, related to technology. We still use old and unreliable technological communication platforms like fax. Second, medical reporting structures are non-standardized, and it's definitely left up to the author on how broad and detailed the PCRs need to be. And interprofessional communication is hampered through inaccessible contact routes. If contact details are not faxed by the referring physician, then there's no way for the family doctor to receive the communications. So while Ryan might not be a real person, he personifies the experiences of many patients with complex conditions like type 1 diabetes. It is clear that interprofessional communication and care coordination needs to be addressed. However, to tackle it, it is vital we get a bird's eye view of the situation so that interventions can be targeted to the areas of most need. After speaking with colleagues, analyzing the information provided, finding out the three overarching themes, we created an interprofessional communication paradigm which simplifies and exemplifies communication breakdown. As you can see, the patient's communication with the family doctor, specialist, endocrinologist, and auxiliary health providers are without barriers. Similarly is the communication between the endocrinologist and the nurse. But the problems start to appear between physicians. So what does that mean? Well, definitely it's complicated. But to figure out the specific whys, the communication paradigm was framed based on the Donabadian model. This framework allows us to present our findings with three components: the structure, the process, and outcomes, and ultimately helped us pinpoint the problem areas. In the communication paradigm, the structure is the context that remains constant. For example, patients with type 1 diabetes visit their endocrinologist a minimum of 2 times a year. So this is part of the communication paradigm structure. The process refers to the interactions between the structures. So what would typically happen at the appointment, an overall checkup. And lastly, the outcomes of the experiences of the stakeholders based on the structures and overall process. For example, the overall maintenance of health for the patient. After mapping out the communication pathways, we were able to locate communication problems in precise locations within the Donabadian framework. So the framework revealed the 5 barriers. First, the physicians within the same institution, when they need to communicate or send referrals, internal email and hospital information systems are used, allowing for seamless communication. However, in Ontario, since different institutions can operate on different EMRs or electronic medical records, and the lack of their interoperability, referrals and PCRs to physicians outside that of the sender will have to be completed by fax or mail. Interinstitutional email cannot be used due to health privacy information laws. And as we know of fax, it is highly unreliable, making it difficult to ensure that the messages have been successfully sent, and with mail, well, delivery is pretty slow. Second, there is an open-ended communication loop. The endocrinologist does not receive any feedback from the family doctor. So if the PCR is able to reach the family doctor, there is no confirmation receipt from their end, letting the sender know that the message is received. Third, the assessment and plan section of a post-consult report is sometimes written unclearly. This reduces the transparency of communication between physicians. 4, the family doctor can't find ways to contact the specialist to receive timely responses if contact information is not forwarded along. And finally, the family doctor does not receive post-consult reports from other specialists to whom the endocrinologist might refer the patient to because their information is not sent along.
So upon discovering these barriers, we have realized that there are several consequences on patient health and well-being that result from inefficient technology and ultimately poor communication. Firstly, if doctors do not have complete knowledge of Ryan or patients' different treatment plans, this increases the risk of adverse treatment interactions. Notably, this creates a reduced efficacy of primary care. Additionally, patients also become burdened with being the messenger between healthcare practitioners who practice from different institutions, which may impact their trust in their health team. Finally, the patient health records also become very fragmented among the various institutions they visit, which can also yield unnecessary reassessments and delay treatments. These are all consequences of broken communication and poor patient health information exchange due to an underutilization of technology. Thus, this underutilization of technology in healthcare can have a direct impact on patient trust in their healthcare experience. The following are limitations of our study. So we only had 14 weeks to complete this project due to constraints in our course timeline. Additionally, we only spoke to those within our personal networks informally, which limited our stakeholders. Also, due to the state of COVID while we were completing this environmental scan, we were limited to speaking with stakeholders virtually. Additionally, all of the information that we had obtained is based on the current scope of healthcare, which has been heavily influenced by the pandemic. And finally, being that we spoke to those within our personal networks, we understand that our findings may be subject to some level of stakeholder bias. So where do we go from here? What can we do with this paradigm? Well, the best first step would be to expand the research scope by increasing the number of participants and the geographical parameters. Due to limitations in time and resources, our project focused on doctors based in downtown Toronto, so mainly from major hospitals such as St. Mike's, Sunnybrook, Women's College Hospital, and a private clinic. However, this problem is systemic. Therefore, it would be more informative to consider the problem on a larger scale, such as the GTA or Northern Ontario. We hope to further this research for our capstone project or our major research project, which we will do by expanding on our scope, which will help verify the findings of our study and give us additional information on other provincial regions. Furthermore, we will share our findings with patient advocacy groups with the intention of collaborating with them. We were very fortunate to connect with a representative from Diabetes Canada who showed interest in our work, so we hope to collaborate with them in the future. Through influential organizations such as Diabetes Canada, we hope to learn how qualitative research projects like ours can help to inform healthcare policymakers. So we'd like to thank you for listening and welcome any questions you may have.
I was on mute. Okay, thanks, Sai and Kim. I think in interest of time, we'll just bring everyone back and have a discussion together. So thank you all for those really interesting talks covering several different themes, all related to health and well-being. So in terms of overall discussion, I'm happy to kick us off. And something that was mentioned across the presentations was that tailoring these technologies to their local context is important for maintaining trust. And while that may be the case, certain systems such as contact tracing or child welfare or networks of endocrinologists and diabetes care need to not only serve a local population, but stakeholders need to understand what's going on with these programs at a larger scale. So whether it's provincially within health regions, or in certain cases, like for example, with the pandemic nationally, right, with the Public Health Agency of Canada. So how do we navigate this trade-off between systems that are very locally tailored to their context, but run the risk of becoming fragmented with no way of being able to harmonize across them to guide programs such as health planning at a larger scale to serve the health of all Ontarians or all people in the GTA or all Canadians? I'm wondering if across your different research projects, you've gained some insight onto navigating that challenge. So feel free to raise your hand or just come off mute. Sure, Camilla, why don't you go ahead?
Sure, I'll just say I think it really depends on the level at which you want, at least for I think for Arena and I's purposes, and then for my own purposes with contact tracing, depends on the level at which the technology is being deployed. So an urban context, while there are things that may scale, there are things that won't scale, right? So if we're designing a technology specific to the context in Toronto, that's very different for a rural Canadian city. So really having an understanding of the people that you're designing for, the context that you're designing for, and as technologists being able to leverage previous research to understand what scales and what doesn't. And then also having an understanding of what is the metric that you're optimizing for. So we know for contact tracing, we're always optimizing for adoption. We want people to be on the app, being able to engage with it meaningfully, being able to trace them, because it doesn't work otherwise. some technologies don't need that skill, don't need that adoption. So I think it's just understanding the context and understanding the tech that you're working with and what you're trying to make happen.
Go ahead, Kim.
Well, actually, your question is kind of perfect because our team and I, for our capstone, that's pretty much what we're going to try and look into. And I think one of the best ways to do it is looking at examples in other places that have been successful in doing something like this. So one of the places that we were looking at is Estonia, and they've managed to have a completely interoperable system that houses their entire national health services and helps with contact tracing, which was actually pretty incredible during COVID. And so potentially learning from how they overcame the same barriers of interactions, privacy, things like that would be really useful in helping us understand how we can tailor it to Ontario's needs then.
And just as a follow-up for you and Sai, do you foresee any major differences in the findings if you compare, in this current stage of the study, you focused on the urban Toronto hospitals, but in the future, if you think about even beyond the greater Toronto area or in northern and rural parts of the province, how do you think your findings may change?
I think the gaps that we found will start to be more prominent the further out from the GTA or industrialized, so to say, areas, because that's when like technology also starts to get spaced out. It's not as easy to facilitate because a lot of the technologies as well focused in downtown. So as we expand our study, we definitely think we're going to see our issues be a lot more complicated and a lot more prominent as we go along.
Right, I can imagine with patients living further out from the downtown core, but if they have to come in every 3 months, drive into St. Mike's, that's a huge burden just to get to the hospital. But with the pandemic and the transition to more virtual care, perhaps that's something that should actually stick around for these patients and save them a 3-hour trip to the city for what might be a very short appointment.
Yeah, actually, there is a company in Hamilton that does a lot of this technology and helping physicians take a look at reports. So for people with diabetes, with their continuous glucose monitoring, that company actually helps pull all that information online. They do all the sorting, the cleaning and whatever, and then they give it to the physician. So so the people don't necessarily have to come in until the physician really needs to see them if it's actually a critical problem. Otherwise, it's something that can be done remotely so that it accommodates for people's accessibility to their healthcare providers as well.
For sure. Mohammed, I see you have your hand up, so please go ahead.
Yes, just to add up, here we are just want to acknowledge that there is a problem, that it will be recognized, and there's no magical solution, that it is by step-by-step project that people should acknowledge at first that there is existing problem, and after that we will dig further deeper and see to what extent these barriers do exist, and hopefully in the future by us and by other researchers they can propose some kind of acceptable solutions for this existing problem.
For sure. This actually also reminds me, Radhika and Ellis, in your project looking at patient engagement with respect to AI all over the world, were there any studies that you found that actually focused on perhaps rural voices or people living in more remote areas, or did you find that your study so far focused on patients living within urban centers, or is that even something that was mentioned in the studies at all?
I guess I can start off the topic, and if Radhika, if you want to add on anything. So yes, there were mentions of rural and urban areas. However, I don't think there was a really clear distinction between how that impacted the use of the AI. It was more like how feasible, how acceptable people were. The same themes came across each of the articles, but in terms of their specific differentiation or making a comparison, that was not necessarily the main focus of most of the studies.
There was actually one study that comes to mind actually was one that looked into different demographics, and because of the way we've been doing the scoping review, all of us have been focusing on different types of studies, but there was one that looked into like bigger cities versus small towns, younger participants versus older participants, whether or not people had like previous experience with AI or previous knowledge about AI versus those that didn't. And yes, so there was a couple of studies that I had read that looked into those types of demographics, and sometimes they were sometimes they were conflicting with each other, but generally what I've been seeing was that bigger cities were more accepting of AI, whereas smaller towns were slightly less accepting. But we are going to be looking into those demographics a little bit more as we continue into the scoping review, because they are generally mentioned, I believe. But I think the most prominent demographic that's looked into is like age range or types of technology being used. So.
Gotcha. And so this now goes back onto Kim, how you were talking about a private company that actually takes people's diabetes information and collates it and synthesizes it to make it useful for clinicians. I'm wondering what you all think about the role of private technology companies in health and well-being, whether there be big tech or startup companies. How do we navigate working with these companies in a way that fosters trust? Or do you think that even that premise is suspect, and that really, with regards to health and wellness space, these technologies should fall squarely within the realm of the public sector to develop, maintain, deploy?
I'll go first. I think we definitely need to partner with private organizations just because of the amount of funding available to have these technologies up and running. But there needs to be then that auditing system of health information, especially with private companies or, well, even public sector. The amount of data or the types of data that are being exchanged needs to be secured and protected, and there needs to be like a standard set out on how and what they do with the information. It's inevitable and happening where we do partner with private companies, and they can be quite useful in helping maintain the health system in general as well. At least I think so.
Camilla and Irina, do you have any comments on that from the perspective of welfare and the foster system? Are there many private companies in this space, or did you find that most of the players were actually public institutions?
Correct me if I'm wrong, I think most of the players are public institutions, Irina?
Yeah, but the child welfare agencies are technically nonprofit, I believe, but they are sort of hired by the Wisconsin Department of Health or each individual's Department of Health to provide services to families and their children.
I think in terms of ownership of data, when it's such sensitive information, in general, I think most people working in this space would probably agree that it should be owned and operated by a nonprofit or a public institution, just because private institutions driving profit from the specific context easily runs into some ethical issues, and at least inquiries. As I mentioned, we don't currently have as strict maybe data ownership laws as we would like. And so I would worry that without those policy and legal frameworks, having private ownership or profit-driven ownership of such sensitive information likely would interfere with the public good. You might find data scientists who disagree, but that's my personal take.
And how do you think we can, if partnership is the way to go, how can we do that in the confines of something like the pandemic, where, you know, you spoke to it with your work related to COVID, there's this immense need to act quickly. So how do we balance the need to act with the sort of due diligence that also needs to happen?
So I think, again, like just using contact tracing or COVID as an example, like the due diligence has to come first, even if it's a time sensitive matter, because without it, the model just won't work. So if you're looking to deploy a contact tracing app that's kind of haphazard, and you don't think about the people we're designing for, you don't think about all those things, then you do run into an issue where it's just not adopted. And so I think a public-private partnership can happen once we have those frameworks. So if we look at like the European model, for example, they have strict rules and regulations and frameworks for who owns what and who gets to use what. But it's really decided at a higher like governmental level, at the EU level, then it's kind of deployed throughout. So I think that's probably a good starting point.
And Sai and Kim, I'm wondering, with your research findings, were your participants mentioning any changes that happened as a result of the pandemic on workflows and care coordination strategies that may have already been challenging? Did you get into that with your research?
Sai, do you want to?
Sure, yes, I will jump in. So of course, with the pandemic, there was a great jump to a lot of virtual care. So I think like one commonality that we kind of heard from all of our stakeholders was that there was actually an ease in the burden when like telemedicine became very like prevalent. So I think that kind of sparked our interest in further pursuing and understanding how technology could kind of progress care coordination and overall, I guess, like the healthcare experience of, I mean, I think our focus is Ontario, hopefully for our capstone project. But in terms of struggles, maybe Kim could speak more to that.
I think having to switch over from completely seeing someone in person at the every 4-month mark was a challenging shift. But overall, just from what the physicians have been saying, it hasn't been much of a difference from a technological point of view.
Gotcha. And a theme across all of your presentations was also participatory design and understanding where participatory design has limitations. I'm curious to think about what you all think regarding how to engage healthcare professionals meaningfully in the participatory design process, because oftentimes they're extremely busy. They have demands to see their own patients in academic centers. They're doing either research or quality improvement or teaching. They're already stretched. And so when you think about the need to design completely new programs or overhaul existing programs, how can we engage healthcare professionals in a way that is sustainable, doesn't already contribute to their burnout? And what can that look like moving forward? Because it seems like there's agreement that this is important to actually design and deploy these technologies in a way that promotes social license. But how can we actually do that? Sai, go ahead.
So this is actually very applicable to our program because in this case, these healthcare practitioners are the end users. And so Something that's drilled into our heads in the translational research program is actively engaging the end users, especially when coming up with new interventions, technology, etc. Now, I think to avoid overburdening these already busy professionals, I think having a large enough sample size is very important. That way you get a lot of different perspectives, but you're not constantly bothering a small group of people who already are busy. But I think it's also important to, something that we learned while carrying out this environmental scan that we did was utilizing technology. So we conducted a lot of our meetings over virtual calls, very, casual, informal, and very brief. And we found that that was not, at least from the feedback that we gathered, not a burden on their end nor our end. So it worked out very well, as opposed to, having to get together in person. And I think that gets a lot more complex. So yeah.
Radhika, go ahead.
Yeah, it's Radhika. Sorry.
Radhika, sorry. All good.
No worries. But I just wanted to bring up the fact that that burnout factor that you're bringing up is an entirely systemic issue. And I don't think it's going to be solved through the fact that it touches upon not being able to adopt and apply different and new technology. I think that touches upon more than just the mental health aspects, and the time aspect as well. I think it actually has more to do with the limited amount of professionals that we have in the field, as well as not utilizing the other professionals and simply putting everything onto doctors and physicians and nursing staff that are in hospitals right now. And I think there may be more applications for people in administrative positions, as well as bringing on more students and bringing on more professionals in general, and just training more people so that we can actually, help everyone in healthcare that we want to.
Camilla and Erna, do you have any parallels from your work with welfare agencies and social workers? Are you finding the same sort of things, or do you think there are meaningful differences as you switch from healthcare to child welfare?
I think there are quite a lot of parallels, especially when it comes to any issues related to the fact that there are problems in each of these sectors because of underlying economic or socioeconomic reasons. So one of the things that we noticed in our work is that there are a lot of stakeholders also involved, sort of similar to the medical space. In our case, on our scenario, it would include foster parents, children, their biological parents, caseworkers, social workers, as well as people in the bureaucratic departments within the DCF, which is the Department of Children's and Families and so on. When we look at studies on their perspectives on technology use in child welfare and the perceptions of child welfare in general, their perceptions of the system is just so different. Everyone wants families to be safe. Everyone wants children to be safe in where they're living in. But how we get there is just so different. So recently there was a study on child welfare stakeholder perceptions towards technology use. And a lot of the biological parents who are in the system really highlighted their general mistrust of the system and how they just don't want the system at all. They're saying, okay, we want resources. The families need resources in order to take care of their children, but they have to be within the system, in the child welfare system, in order to get these services. But then once you're in the system, then there's a lot of, caveats. You're in the system, you're recorded, and that stigmatizes you going forward. So there are some people who are totally against child welfare services in general. And then there's also, some people in biological parents who understand that there are, needs to be protective measures in the public sector that can safeguard the children. And then you also have caseworkers who are facing deadlines. They have a lot of work. They're facing budgetary issues. And these people also want to care for the children. And they have to, work with policy constraints. And then they're also trying to work with these parents or biological parents who are very mistrustful of the system in general. So they have to build these relationships too. So I think one of the things that we've noticed that is quite difficult in child welfare, and I imagine this also relates back to the medical sector as well, is that there's so many different conflicting stakeholder values or priorities that it's really hard to build something that works for everyone. And if you're optimizing for one thing, then you might be losing something else. And this is a struggle that's just constantly ongoing. Having all the stakeholders on board is good, but also it makes it so difficult as well, because we have so many divergent opinions going on that it's very hard to sort of reach middle ground. And it's a it's a continuous challenge, I think. But one of the things that we've noticed from our research is we need a lot of context. We still need to know what the stakeholders are saying, but who we choose to listen to and how much of each stakeholder we choose to listen to is a completely different question.
And to wrap off, I think we've seen from all of the talks this morning that this space is incredibly interdisciplinary, and we need to bring these different perspectives together to at least try to understand where they're coming from and find a way forward. But how do we equip end users or stakeholders across these different disciplines to be able to contribute meaningfully? Because these technologies often have their own language associated with them, whether it's machine learning or telemedicine. Professionals or patients in these areas may not necessarily even have the vocabulary to describe their issues. So how can we prepare our stakeholders to provide us with the feedback that we need to improve these systems? Go ahead.
I'm just going to speak. So I think that's kind of where translational research really does come in, because one of the focuses that we have is science communication and bridging those gaps between patients and their the professional stakeholders. So I really do think it's more of a matter of bringing those two groups together and having a moderator similar to how we do it in conferences, and making sure that we have a guide going through the process with our participants essentially. And basically when there's confusion, when there's a difference of opinions, then you have someone there that can provide something to kind of bring everyone onto the same page again. And I think that's where you can bring in other than just your patients and your stakeholders, that's where you bring in a moderator that's a little bit more neutral and can help those people get together.
Any other comments or closing thoughts from any of our panelists this morning? Okay, yeah, seeing none, I will conclude this session by thanking all of you for taking the time to share your interesting research projects. We covered a lot of ground this morning, but learned a lot in terms of how we can think about trust and facilitate trust within health and child welfare and beyond. So I'll turn it back over to Asmita to provide some housekeeping in terms of closing up this session and introducing the afternoon session. Thanks again.
Thank you, Vinyas, for the excellent moderation, and to all the presenters who presented so far. So we have an afternoon session, which is going to be very exciting as well. So maybe we all can take a lunch break now and come back at 12:30, which is when I'll introduce the afternoon session and the moderator. And yeah, so let's just come back at 12:30, same link.